for inviting and for the kind introduction. I'll just share my screen, please. Yeah. So I've made the presentation with epileptic encephalopathies with focus on EEG patterns as instructed. Nothing to disclose. I hope my slides are moving. Dr. Manjari, are my slides moving?
Yes.
Yeah, okay. Yeah, so the outline, how I propose to proceed is having an overview of the pediatric epilepsy syndromes and epileptic encephalopathies with the terminologies evolving over years. The definitions, so what are the case-based pediatric epileptic encephalopathies will, some cases I have crossed for you, and the EEG descriptions of various epileptic encephalopathies. So basically, Williams James West in 1841 described West syndrome. From that time onwards till now, there has been change in new conditions have been described. Landau-Kleffner in 1957, LGS in 1966, and in 2001. It was it was described that conditions in which epileptiform abnormalities are believed to contribute for a progressive encephalopathy, and then 2010, the ILE had said that epileptic activity itself might contribute to severe cognitive and behavioral impairment, and more than what that underlying pathology would be given, and it can be worsening with time. In 2017 comes up, they put the term that developmental impact may be there, which may be independent of the epileptic encephalopathy and may precede in some situations. Then comes this 2022, and in 2020 for the infants, they've defined epilepsy syndromes as characteristic cluster of clinical and EEG features, often supported by the investigations for etiological findings, and they have called it by structural, genetic, metabolic, immune, or infectious. And they have asked for 3 criteria that mandatory will be criteria must be present. Alerts must be that the criteria that are generally absent but may be present in some case, and there are some exclusionary criteria which should be absent. And they have defined as developmental and epileptic encephalopathies will come into this category, plus certain etiology-specific syndromes will also have the epileptic encephalopathies. Coming for the classification for the childhood, for 2022, they have again said that childhood onset epilepsy syndrome, most of which have mandatory seizure types and interictal EEG features, classified as 3 types: the self-limited focal epilepsies, the generalized epilepsies, and the development and or epileptic encephalopathies. So this is the self-limited one, the flow chart, the figure which they have, and then this is for the generalized, and this is for the developmental and epileptic encephalopathies. So basically, we have discussed that ILE has said that epileptiform activity itself contributes to severe cognitive and behavioral impairments beyond that expected from an underlying pathology alone. I'm repeating this thing because it's very important to understand. And it is regarded as a triad of features of seizures, epileptiform activity on the EEG, and adverse effects on development, cognition, and often behavior. And they generally are drug refractory. And epileptic encephalopathies generally may begin in the infancy and childhood, but there are certain progressive myoclonic epilepsies which can come later in age. So this epileptiform discharges, they have an impact on cognition, either by inhibition of the distant brain areas and connected with the epileptic foci, and that is how the thalamocortical networks have been implicated, or alteration of neural development, or the transient effects of information processing. So it is important to have optimal treatment for these patients, and both ways, they can certain times they are being, because they're drug refractory, too many medications are being given. So we have to see and optimize, and that is why it's very important to understand that the anti-seizure medications can have problems. And we had seen that 43 out of 100, that means 43% children on of epilepsy had some behavioral comorbidities, and with the polytherapy it was much more. And most of the, out of a subset out of these patients of 100, we had seen 73 had, and 23% had a comorbid ADHD. And so epilepsy, cognition, and behavior are all interrelated. So this term which came up in 2017. They said that the developmental and epileptic encephalopathy is the formal terminology which came up, and DEE denotes children who have an abnormal development secondary to the underlying cause in addition to an epileptic encephalopathy. Many of the genes causing these epileptic encephalopathies are recognized to independently adversely impact the development. So it refers to a developmental impairment without frequent developmental encephalopathies refers to a developmental impairment without frequent epileptiform activity, such as in the child or the adult with intellectual disability. And they have also mentioned in the 2022 that the developmental encephalopathy in persons who have already completed their development, they would like to call it as epilepsy syndrome with progressive neurological deterioration, like, with Fires and Rasmussen's can become. So basically now when we see it, the spectrum from the ages, so from birth onwards till adulthood. So initially you have the less than 3 months onset, you have the Ohtahara, EME, and epilepsy of infancy with migrating focal seizures. And I will mention that how the new nomenclature has come for Ohtahara and EME. Then infantile onset from 3 months to 2 years will classically you start with West syndrome, you have Dravet, and West syndrome going on to be LGS, and then you also have the LKS CSWS pattern which is there, which can be seen. So now we going age-wise, and this is a 27-day-old baby with abnormal movements. There was no perinatal insult, obviously, and then obvious perinatal insult, and there was neurological examination was within normal limit. This child was having recurrent episodes of tonic spasms. And when we saw the EEG, there was a bilateral attenuation of the background activity, and there was a burst suppression pattern coming from the right hemisphere. And the black arrow is some of the burst, and the thin blue arrows are the suppression which is coming in the picture. So what is burst suppression pattern? Burst suppression pattern is characterized, by not so much by the features, it is because of the amplitude difference. What we are talking about is very important. In this, what happens is the features within the burst or the suppression, but there is a contrasting adjacent amplitudes. The amplitudes of burst may vary from a low less than 20 microvolt to high of more than 100 microvolt, but most often it is between 20 to 100 microvolt. And so it is similarly a suppression may vary in amplitude, but it is almost always within the range of cerebral inactivity to median amplitude of less than 50 microvolt. Since the abrupt change in amplitude is essential in the definition of this pattern, the amplitude difference must be clearly as visible, and this difference is usually close to or greater than 50% decrease. So you can classically see this in this picture. And so this is this one, you have the burst pattern, the burst of irregular, predominantly slow wave activity occurring without preserved waveform and periodicity. So bursts are lasting for 1 to 2 seconds are there, which can be seen in this classical picture. And this another one is another burst suppression pattern. It shows irregular mixed frequency activity having a duration of 3 to 4 seconds and are separated by suppressions of 2 to 3 seconds. So there is that, you can see it is a gross inequality which is there, and there's a gross difference which is there, so you can make out that with more than 50% differentiation. This same child, what we had talked about, had right frontal FCD, and that could have been seen in this MRI, in which they had the T2 fair hyperintensities in the right frontal regions with a dysplastic thickened cortex. So Ohtahara versus EME, and Ohtahara has classically got tonic spasms, and EME has got electric myoclonias, and you may have focal seizures, and generally you have malformations in Ohtahara, and you may have genetic and metabolic causes in EME, and you may have a burst suppression which will be pseudo-rhythmic and continuous in sleep and wake cycle, starts earlier and is shorter in duration in Ohtahara syndrome, and it's probably accentuated by the sleep, and in the cases of EME, and may not occur in wakefulness, starts later and lasts longer. So, I mean, they are, but now, the 2017, they have said that these two conditions have a significant overlap. And that is why the task force, they recommended that both of them should come under early infantile developmental and epileptic encephalopathies, EIDE, since 2017. So they are now, because of the similarities, they have been said. So that is how we have EID has onset in the first 3 months of life with frequent seizures and frequently drug resistance, with the abnormal neuroexamination and developmental impairment, and an abnormal interictal EEG, which may include a burst suppression pattern, and neuroimaging and all, and metabolic genetic testing will be giving etiological classification in up to 80% of the cases. So I think I will not go into details about that beyond this. It's not very common, but it is there, and we have to understand. And they generally we have to pick up early, and they are really drug these cases. And the seizure semiology has mostly, can be tonic seizures, myoclonic seizures, epileptic spasms, and sequential seizures may include various kinds of tonic, clonic, or autonomic components can be there, and can ultimately evolve into IESS with burst suppression or multifocal EEG abnormalities later on, with some cases to a Hips arrhythmia pattern. So they can be evolution beyond this. There are many genetic conditions which have been identified along with this EIDE, and just for us to understand. And we have to understand that the interictal EEG is abnormal and may show a burst suppression pattern with multifocal spikes, spike waves of sharp waves. And it is usually seen both in wakefulness and sleep, and is unresponsive to stimulation. And in the ictal one, they can be, focal or symmetric. With tonic seizures, you may have a burst suppression pattern, which is there with the emergence of low voltage, high frequency, fast activity. This was an interictal record showing a burst suppression pattern. And then, here you can see, you're saying that you are having a, evolution of the discharges in terms of frequency and amplitude and distribution in this. Now coming to the, so this was, this is a very, sort of initially used to be called catastrophic epilepsies initially, but now we do not use those terms any longer, but these both have been now combined into one. Now coming to a 2-month-old girl with a smooth perinatal transition, having neonatal onset seizures, which were focal tonic with impaired awareness and a migratory character. There was encephalopathy, no focal deficits were there. And no dysmorphism, and neurocutaneous markers, no family history, and relentless progression. And what happens is there was a if you see in this, there is an ictal record which is showing monophoric slow waves, 4 to 5 hertz epileptic discharges from the right hemisphere in this child. And that time there is a tonic spasm coming in the left side. And in this one, there is, if you see, there is a tonic spasm from the right side, and ictal discharges showing the epileptic discharges from the left hemisphere. And here you're getting it discharges from the bilateral hemispheres. So the, KCNT1 was on the whole exome sequencing was identified. So this was the developmental and epileptic encephalopathy with KCNT1. So this is epilepsy of infancy with migrating seizures, focal seizures, and this also has, we will not go into more detail than that, but you can understand. And the EEG, video EEG was very classical, and the onset is usually in the first 6 months, and they may have a focal motor tonic, clonic or tonic seizures, which are mandatory for diagnosis. And you could see the migratory nature, and the EEG you could see. So that EEG you could see very clearly in this case. And we've also reported some patients of KCNT1, and one of these children was not quinidine responsive, and ultimately had responded to ketogenic diet. Now, when you are going beyond this, and then you have the classical, this was a 1-year-old child who had developmental delay and sudden jerky movements since 6 months of age, and lost neck control, which the child had gained by 6 months post onset of jerks. It was in clusters, 4 to 5 per cluster, and more on awakening. And there was history of hypoglycemic insult at birth. MRI showed bilateral parieto-occipital white matter gliotic changes, and there was hypertonia. So you can see flexor spasms, which are happening in clusters in this child. So this is the classical West syndrome, which is very common. And as I mentioned to you, was reported by William James West on his own son. And you have children with epileptic spasms in clusters with EEG showing hips arrhythmia and or its variants and developmental delay. And so that is something which we have to keep in mind. And you have numerous etiologies, and you have a lot of differential diagnoses as well. And obviously what we had that earlier, the earlier onset developmental and epileptic encephalopathies or myoclonic epilepsies or a benign sleep myoclonus or hyperplexia and head drops and Differ syndrome secondary to GR. We've seen patients with that and has been mistaken for having spasms or shuddering attacks. So basically, you have brief tonic contractions of the axial muscles, each typically lasting for less than 3 seconds, which may be flexor, extensor, or mixed in nature. And there are diagnostic criteria, which I mentioned. The hips arrhythmia is an interictal EEG finding, mostly in non-REM sleep. And you should actually have a full sleep-wake cycle in these small children to miss these, to avoid missing these hips arrhythmia in these. There are certain variants which are called modified hips arrhythmia and occur in up to 69% and of these children. So this hips arrhythmia is a high voltage, completely disorganized and a chaotic pattern of consisting of random high voltage slow waves and spikes. These spikes vary from moment to moment, but also from both in location and duration. And this is the chaotic, the record which you can see. In classical hips arrhythmia. In modified hips arrhythmia, you may have variable degrees of attenuation, which is coming in between. You can see in this situation. And then, this one also again with the attenuation and coming in between. And again, in this one also, you may have asymmetric cases of hips arrhythmia, which can occur in this situation, or you may have this is also saying a asymmetric, which is again modified hips arrhythmia. So there are certain kinds of hips, and you may have asynchronous activities also coming. So there are various kinds of modifications of hips arrhythmia, which account for about 2/3 of these cases. We had studied the prognostic utility of a Kramer global scale of hips arrhythmia and found that, we could predict, epilepsy outcome and neurodevelopment, but not the neurodevelopmental outcome with the help of the Kramer global scale as well as EHS in West syndrome. In lissencephaly patients, we had tried to, correlate the EEG correlates with the clinic, with the clinical response, the electrographic pattern of recognition in lissencephaly in pattern 1, 2, and 3. And we found the pattern 1 was of more classical lissencephaly, and that could predict. For we will not go into detail about the West syndrome thing, but yes, you have to give ACTH or steroids or vigabatrin, specifically if it's associated with tuberous sclerosis. Now we go beyond. Now, this is a 2-year-old girl brought to pediatric emergency with status epilepticus, was symptomatic since 3 months of age, had high-grade fever after the Pentavac vaccine, and followed by seizures with abnormal head turning to one side, followed by bilateral tonic-clonic movements for 10 minutes or so. So there were daily episodes of seizures with focal hemiclonic, changing laterality with impaired awareness. And born by a non-consanguineous marriage, had no adverse perinatal events, and had global developmental delay with some autistic trait, and MRI was normal. This child actually had Dravet syndrome, which is severe myoclonic epilepsy of infancy, and mutation in the SCN1A is seen in 80 to 85%. Other genes are also have been implicated in these situations. Presentation like in this case is in the first year of life, and there is a proposed risk score for screening of them. You have differential diagnosis, and you have to differentiate between Jeffs plus and LGS commonly in this situation. And in the EEG, if you see the EEG may be a normal or slow prior to 2 years. Slowing is typical after 2 years of age. And the interictal discharges are often focal, multifocal, and generalized and appear after 2 years of age. In patients with sleep clusters of seizures, interictal frontal discharges are often seen, and a photoparoxysmal response occurs in 15% of the patients. So this is the patient in which you can see In this, you can see in the discharges which are coming, and in the left parieto-occipital, right centroparietal, and right temporo-occipital regions. So you can see this marked very well with the arrow. So this was the next case is a 3-year-old boy with the history of adverse perinatal events with global developmental delay, having spastic quadripartite CP, and history of spasms since 6 months of age, which resolved after ECTH. And then after that, developed, for last 6 months, had multiple semiology of seizures, suggestive of tonic seizures and atypical absences. And there was periventricular leukomalacia with extensive white matter volume loss, and this sleep EEG showed polyspike wave discharges correlate of myoclonic discharges. And then this the sleep EEG in this stage, the same child is showing generalized paroxysmal fast activity, and this is again polyspike wave discharges with generalized paroxysmal fast activity. So the classical, this is a representation of Lennox-Gastaut syndrome, which has tonic, atonic, and atypical absence seizures, at least 2 of them, and generalized slow spike wave discharges, and you have episodic fast activity. So this is the syndrome which comes generally between 1 and 7 years of age, peaks around 3 to 5 years, and they have multiple etiologies. You may have evolution from West syndrome. So basically, what we have to understand that the interictal discharges may, at onset, may consist of an abnormal background with or without the slow wave discharges. And the EEG posterior dominant background is slowed in majority with LGS and usually correlates with the degree of cognitive impairment. The characteristic interictal pattern is diffuse and slow, which is 2 to 2.5 Hertz spike and wave discharges with frontal predominance. And you may have paroxysmal fast activity, can often but not always be seen during slow wave sleep, and has been considered as a diagnostic by of LGS by most authors. The bursts typically are about 10 Hertz of faster frequency and are diffusely distributed in the anterior prominence. And the ictal patterns associated will depend on the various seizure types. So this slow generalized 1 to 2 Hertz spike and wave discharges with bifrontal predominance. And this PFA, which is very important, these are bursting beta frequency range activity that may either be focal or generalized. They have abrupt appearance of a fast, regular, irregular rhythm that usually differs from the background and its amplitude. You may have focal PFAs, which may last from 0.25 to 2 seconds, and generalized PFAs, which last for about 3 seconds, but may last for up to 18 seconds. So this is, to summarize, in the LGS, you have, this, you can see this generalized 1.5 to 2.5 Hertz slow spike and wave activity with frontocentral predominance, and this PFAs which are there, which are burst of beta range, generalized fast activity, background of slow spike and wave activity with no discernible background. Right? So, and what are the differentials? You may have muscle artifacts which are heterogeneous in terms of frequency components and disorganized. You may also have this beta activity which can get confused, or you may have spindles which may get confused. So that you have to keep in mind. We will not talk about the management. Then we, they are mostly drug resistant, and lots of, so you have our DRE management will be there for Lennox-Gastaut syndrome. And next spectrum comes as electrical status epilepticus during slow sleep, and continuous spikes and wave during slow sleep. So it is the ESES, CSWS thing. So it's an epileptic encephalopathy. CSWS is partially reversible, age-related childhood epileptic encephalopathy characterized by the EEG suggestive of CSWS, seizures, and neuropsychological impairment. So you have continuous spikes and wave during non-REM sleep is a prerequisite for the diagnosis of this syndrome. So this is a case of a 6-year-old boy who had HIE, global developmental delay, a left hemiparetic cerebral palsy, had first episode of seizure, right focal, at 2 years of age. Thereafter, he had infrequent seizures, but over the last 1 year, he was having significant behavioral problems, stubbornness, inattention, hyperactivity, and decline in cognition, and the MRI showed right frontoparietal cleusis. So this EEG, sleep EEG, showed spike wave discharges which are generalized and prominent over the right centroparietal part with sleep potentiation. So on an awake EEG, there was a significant decrease in the discharges. So see, this was the sleep EEG and this is the awake EEG. So this is ESCS, it is the ILE has said that it was actually first reported in 1971 as subclinical electrical status epilepticus induced by sleep in children. Then ILE said that continuous spike and wave during sleep as a specific epilepsy syndrome characterized by continuous diffuse spike waves occurring during slow wave speak related to the development of neurocognitive defects. So there have been guidelines for the same. We need to understand the spike wave index. The spike wave, what is spike wave index? This is the percentage of epileptiform activity during sleep can be expressed as a spike wave index, originally described as percentage of diffuse spikes and waves during slow wave speak. And the duration of CSWS is quantitatively expressed as the SWI, which is a sum of all the spike slow wave complexes in minutes multiplied by 100 and divided by the total duration of non-REM sleep. Various criteria have been, defined, and at least of SWI of at least 85% has taken for the diagnosis. So you see the number of seconds per epoch with discharges are being highlighted, and then number of seconds per epoch with discharges again being highlighted, right? That was awake, this is sleep. Then you have the number of 1 second blocks containing spike wave discharges over a continuous 15 minutes, 90-second period divided by 900. So that is how you calculate the your SWI, which is to be calculated. And you consider, how do you calculate? Considering the percentage of diffuse spikes and waves during the whole night, non-REM sleep can be taken, or you can take percentage of spikes and wave during at least 15 minutes of slow wave speak can be taken, or percentage spikes and wave during the total duration of each cycle of slow wave can be taken. So there are various ways they have been suggested. So you have understood that it is there, and now mostly you take as a non-REM of more than 85% to be taken as, for the CSWS pattern. And you can have a lot of etiologies to it. There is a lot of genetic etiology as well correlated with it. And the onset of seizures come between 2 months to 12 years, with the peaking around 4 to 5 years. And there is a male predominance is there. There is a lot of studies going on in the neuronal network and all. And the first stage is before the discovery of CSWS. The first seizure is usually nocturnal in half of the cases. You may have a unilateral convulsions. They may be simple focal, motor clonic, or complex focal or myoclonic seizures, or even GTCS. They are infrequent and mainly nocturnal. The second stage, which commonly starts 1 to 2 years after the first seizure. This is the active duration of CSWS, and it may be ranging from several months to 6 to 7 years. And the habitual seizures of the patients becomes frequent, and new types of seizures may come. There may be multiple types of seizures, and convulsive seizures are predominantly nocturnal. Clonic seizures do not occur in any stage in this situation. And the third stage is of clinical EEG remission, which is, variable duration from months to usually 2 to 7 years from onset. Seizures remit and the EEG improves. Despite some improvement, many of the children may have complex neuropsychological impairments which may persist. So these are the various 3 stages which we talked about. And, this was an 8-year-old boy with Rolandic epilepsy, normal development started showing some declining academic performance. When alert, the EEG showed infrequent clusters of focal sharp slow wave discharges left, which became continuous during sleep. So ESCS has been also graded. Gradation is depending on, gradation of 0 to 4 has been there depending on the spike waves, and various other ways of categorizing them has also been there. And there are studies which have done, and you have to, they are generally, we end up giving steroids in that. We are not be talking much about them, but yes, yeah, you do get anti-seizure medication, but steroids have an important role in this situation. A lot of now studies are going on to understand, and we are also doing transcranial magnetic stimulation at AIMS for these patients, and trying to understand what is happening in the, on the TMS parameters in these children, and why they are, why are they predisposed to having ESCS. Now, after this, we come to Another case, which is a 4-year-old boy with a pre-morbid normal status and no adverse perinatal events, had gradual regression of language milestones over last 3 months. So he was normally developmentally till 4 years, had gradual regression of language milestones, was unable to respond to questions asked, and he was unable to write and express. Had one episode of left focal seizures, brain was normal, MRI was normal, epilepsy protocol, and the sleep EEG showed, the which captured at microvolt per centimeter sensitivity may have to be decreased to visualize properly because of high amplitude discharges. And this awake EEG was, also it is shown that the high amplitude discharges which were there, it has been the sensitivity has been changed. This child had Landau-Kleffner syndrome, which is acquired aphasia with convulsive disorders and has an age-related epileptic encephalopathy. It is a clinical variant of epileptic encephalopathy with CSWS, and both syndromes are two facets of the same entity, in which the type of neuropsychological dysfunction depends on the local of interictal foci, frontal in epilepsy with CSWS and temporal in LKS. So that is, I will not go into details for that, for covering the other things. So the EEG in this have a sharp, slow wave focal discharges, 1 to 3 hertz, unilateral or bilateral, predominantly in the temporal regions, and the discharges become more frequent and extensive in non-REM sleep. So posterior temporal foci of sharp slow wave complexes that are often multifocal and bisynchronous, markedly facilitated by non-REM sleep. So this can be seen so we can understand how we can differentiate from CSWS. This was again a 4-year-old child with autistic regression and low clinical seizures. And you can see clusters of sharp slow wave focal discharges, maximum around right posterior temporal regions. And sleep EEG during which the paroxysms have becoming continuous. So LKS versus epilepsy with CSWS. So we can see that, we talked about the temporal and frontal regions, and we also understand that it is a primary, the behavioral problems can be seen more along with in the CSWS pattern. And the management valproate is the first line of action, and what we try to give. And next is epilepsy with myoclonic aesthetic seizures, the DO syndrome, and it onset is between 7 months to 6 years, has a strong genetic predisposition with high incidence of seizures and or genetic EEG patterns, and mostly normal development and no neurological deficit before onset, primary generalized myoclonic aesthetic or myoclonic aesthetic seizures, short absences, and mostly GTCS, and no tonic seizures or tonic drop attacks during daytime, and the generalized EEG pattern shows spikes and waves and photosensitivity 4 to 7 hertz with no multifocal EEG abnormalities. And in 2/3, febrile and afebrile GTCS appear first, several months prior to the onset of myoclonic aesthetic seizures. There are some diagnostic criteria, and the only thing is the children with DOs are normal prior to development of seizures, have a strong family history of idiopathic generalized epilepsy, and the background EEG and brain imaging are normal in this situation. In the EEG, interictal EEG may be normal at the stage of febrile or afebrile, and when myoclonic atonic seizures appear, there are frequent clusters of 2 to 3 hertz, generalized proximal sharp wave activity interrupted by high amplitude slow waves. And in children with predominantly myoclonic seizures, paroxysm of irregular spikes and polyspike wave patterns come. And ictal EEGs of myoclonic and atonic seizures will manifest with discharges of irregular spike and wave or polyspike wave complexes at 2.5 to 3 hertz or more. So you can see this was a 6-year-old boy with the background activities normal, but they are frequent at least every 10 seconds, 3 to 6 hertz, generalized proximal short wave discharges with anterior maximum. They are brief for around 1 to 4 seconds. They are frequently associated with single jerks of mainly the shoulders, but also on other occasions of the thumb and eyelids. So this was the child who had DO syndrome, and valproate is effective, and obviously, and many of them, we will not discuss in detail beyond that. to end the spectrum of epileptic encephalopathies, which can be occurring at a later age, are the progressive myoclonic epilepsies, and they are characterized by focal and generalized seizures, myoclonus, and progressive neurological dysfunction, including cerebral ataxia and cognitive deterioration. They're refractive to conventional ASMs. Photosensitivity may be there in certain, it can be there in certain progressive myoclonic epilepsies, and there are a wide range of them. And most commonly what we see has SSP. This is a 8-year-old boy with no adverse perinatal event, was not vaccinated, and symptomatic for 2 years, with behavioral abnormalities noted for the last 2 years in the form of inattention and hyperactivity, repeated falls with jerks throughout the day, and progressively increasing in frequency for the last 1 year. There was a cognitive decline noticed, and there was spasticity and dystonia. This is classical clinical scenario of SSP, and the MRI can show cerebral atrophy and hyperintensities in periventricular white matter, followed by spread into deep brain structures and the brainstem. So the diagnostic criteria has the elevated CSF antibodies, and there are some typical EEG findings. So in this EEG findings, these are bilateral periodic epileptiform discharges which can be seen. And the paper speed is very important in this situation. So you see, by changing the paper speed, you could see it very nicely, the discharges in this. So these are quasi-periodic in nature. So this is classically accompanied by bipeds of very high amplitude, long duration, and long inter-discharge interval. And they have an average amplitude of 500 microvolts and commonly range from 100 to 1000 microvolts. However, they can be as high as 1500 microvolt. The duration is from 0.5 to 3 seconds, and they commonly recur after every 3 to 20 seconds. And they may recur infrequently, initially every 5 minutes. And then you need to understand that the occurrence of bipeds with such long inter-discharge intervals is so characteristic of SSP that a pattern with these features has been proposed to be pathognomic. Another characteristic features is that they may be asynchrony in 15% of the situations. So this one, these stereotype complexes with high voltage diphasic waves occurring synchronously throughout the recording and usually clinically associated with myoclonic jerks are pathognomic feature of SSP slow wave complexes or Rader-Merker complexes, and they are seen in about 2/3 to 4/5 of these patients. And anyway, we don't go into the management part of this. Yes, of course, you give isoprenosine, and interferon is tried in some situations, but it's got a poor outcome. NCL is something which we have helped by EEG to diagnose in certain situations. This was a 4-year-old boy who was born out of a 3rd-degree consanguineous marriage and no adverse perinatal event, and had abnormal cycloid movements, seizures onset 2 years of age, poor language skills, and progressive loss of motor function and cognitive skill past 6 months. Head circumference was in the -1.5 SD, and there was a disc pallor, and there was no other organomegaly. So this one is an autosomal recessive progressive neurodegeneration, which is there, which may include having a progressive loss of vision, myoclonic jerks, and you may have loss of cognitive function and pyramidal and extrapyramidal motor dysfunction. So intractable epilepsy with cognitive motor decline and progressive ocular disturbance can be there. And you have some classifications, which I need not go, and diagnostic criteria, but the EEG is important. You may have occipital spike and wave, polyspikes, waves, multifocal spike and wave discharges with low phoric stimulation at 1 to 2 hertz. And we were able to pick up in this situation patient, and then we had confirmed it by enzyme and further by whole exome in this case. So this is important that you have spike waves, polyspikes waves, and multifocal spikes and wave with photosensitivity important, and occipital spikes with low phoric stimulation are important to understand. So management, we will not talk about management. Newer things are coming up. This was the child which I had presented at this autosomal, having autism, epilepsy, neuroregression, and the response on low photic stimulation had helped us come to a diagnosis in this situation. So a 10-second EEG box of the index case had helped, with the showing a posterior dominant photoparoxysmal response. And you may also have for Ulrich's and Lafora bodies. This was a 10-year-old girl, developmentally normal premorbidly, had jerks during morning hours after awakening for last 1 year, and now complaining of sudden jerks exacerbated by stress or during some household activities. So there was no cognitive decline. And so it turned out to be having cortical myoclonus, generalized tonic discharges with mild progressive ataxia had turned out to be the myoclonic epilepsy. And you can have other symptoms. Neurological signs may be minimal, cognitive functions may be well preserved in these situations, but EEG had can show frequent spontaneous jerks are seen following generalized burst of spikes, and they can also occur without EEG changes, and a generalized burst of poly spikes during the 0.5 hertz photic stimulation is elicited by eye closure rather than a flash. So basically, we can have some guide for these progressive myoclonic epilepsies, characteristic finding from the SSP with the paper speed also helping in that situation, and the NCL with the photic thing. So you do have helping in this situation also, for other, for the Unreached Lundberg disease also we can have. So basically, even for Lafora bodies, in which you may have first symptoms of GTCS, and then later on you may have, typical occipital seizures, and myoclonus can be there with rapidly progressive dementia. In those situations, you may have behavioral abnormalities, cerebellar signs, and visual deterioration. And in that also, the EEG can be diffusely slow with frequent near continuous brief bursts of polyspikes. And it is important to understand that you may have some guidance coming from the EEG in all these progressive myoclonic epilepsies, and there may be evaluation of, in all of these various, PMEs for this. There are certain specific phenotypes which are there with MRF. You may have cortical myoclonus ataxia with mild myopathy and cognitive impairment, having a progressively slow background in the EEG with generalized polyspike, spike, and slow wave discharges can be there. And giant visual egg-boat potentials, if we do that, can be find out. Even in Gauchers, you may have non-progressive isolated horizontal supranuclear gaze palsy, seizures and myoclonus and spasticity, ataxia and dementia, and you may have multiple spike and rhythmic shock waves, which can be seen, and you may have photomyoclonic or photomyogenic response, and you may also have SSPs are often joint, very giant in these situations if we do. Also, you have a cherry red spot myoclonus syndrome, which is type 1 sialidosis, which can be also helped by EEG abnormalities of low voltage fast activity and having a central fast rhythm. And photic stimulation can also have some support. Angelman syndrome is also having, which is has a genetic defect, has severe developmental delay and speech impairment, ataxia, and myoclonic jerks, generally having a happy demeanor with excessive, having paroxysms of laughter. These children have high amplitude bifrontal delta rhythm with a notch in the descending limb. And this had helped us in diagnosing in one of these children of ours. And you have the high amplitude bifrontal delta rhythm with the notch in the descending limb. So there are, we can get help by many EEGs in many of the PMEs. So to conclude, epileptic encephalopathy is where the epileptiform activity itself contributes to severe cognitive and behavioral impairments beyond that expected for the underlying pathology alone. Early infantile developmental and epileptic encephalopathy includes the Ohtahara and the EME that has a background abnormality and burst suppression pattern. And West syndrome is an epileptic spasm in clusters with EEG showing hypsarrhythmia or its variants and developmental delay. Hypsarrhythmia includes high voltage, completely disorganized and chaotic pattern consisting of random high voltage wakes and spikes. And LGS is a childhood epileptic encephalopathy characterized by polymorphic intractable seizures, cognitive and behavioral abnormalities with characteristic EEG with fast and slow activity less than 2.5 hertz. The EEG has a posterior dominant background and slowed with characteristic ictal pattern of diffuse activity of 2 to 2.5 hertz, and wave with the frontal dominance with PFAs can be seen. And coming to CSWS, the quantitatively expression of the spike wave index, which is the sum of all spike slow wave complexes in minutes multiplied by 100 and divided by the total duration of non-REM sleep in minutes. Children with DOOs are normal prior to development of seizures, have a strong family history, and the background EEG and brain imaging are normal. The quasi-periodic generalized symmetrical large amplitude spike and slow wave discharges with attenuation in between lasting 4 or 5 seconds is suggestive of SSP. So we see that, you can have a lot of aids, a lot of patterns which are there on the EEG for various, epileptic encephalopathies. Thank you for your patient listening. I would be very happy to answer any queries.
Yeah, so the first question, Dr. Shefali, is how do you differentiate between suppression and attenuation? And this is asked by Dr. Russell.
Okay, so when I was talking about the, classically definition, what was there when you're talking about the definition of the burst suppression pattern, you have to see a comparison in both the sides, and it is important with the burst suppression. It is characterized by that, you have the burst will be there, which will be varying from 20 microvolt to 100 microvolt, but mostly between 20 to 100, and the suppression which will be there, which will be above the electrocerebral inactivity to a median amplitude of 50 microvolt. So you see classically an abrupt change in the slides which when I had shown in the epochs, you will say that is the abrupt change in the amplitude is the essential for the definition of the pattern, and it should be clearly visible, and it is usually close to or more than 50% decrease which is there, which is going to be seen, and that is how it causes a burst suppression pattern. And if it is going to be that is why the differential will be coming. So burst suppression will be abrupt change is going to be coming into
and
the thing.
His question is, what is the amplitude for attenuation versus the amplitude for suppression?
So for the attenuation, it is going to be much more than that, but they will not be an abrupt change. Here, when you're classically defining burst suppression pattern, as you saw on those epochs, there will going to be there's going to be a definite change. You can see abrupt change, which will be there. That is how it will see a very high activity with that less than 50 microvolt, which is abrupt change. The abruptness with which it comes, and it is going to be, that is will be showing the suppression in that situation.
When you see modified hips arrhythmia with burst suppression pattern with spasms in 6 months, should we call it West syndrome or Otohara variant? Does it matter with the management?
See, once you have the OTA, we understand all this early infantile, this DEE, what we have said, is going to evolve into the West syndrome. So that gets, and we have seen in our cohorts that we have seen, which we had published long back in the early 2000s, that, the cohort, they do involve into EIE, which used to be called that time, now which is called EIDEE, going into developing West syndrome and LGS. So that is okay. So once you're getting an hips arrhythmia variant, so and if the child is, depending on the clinical thing, if the child has now started getting spasms, then you have a hips arrhythmia, you can go ahead is calling as a West syndrome thing. Because it is evolving. So there is a spectrum, EIDE, West syndrome, going to LGS.
So another attendee has asked, explain the difference between developmental encephalopathy, epileptic encephalopathy, developmental and epileptic encephalopathy, and static encephalopathy.
See, static encephalopathy is when you have a damage to the brain, which is one time, right? That is what is a static encephalopathy, and that is classically, which we talk about, is we're talking about that in having a cerebral palsy, which you have a static one-time insult to the brain, but the child may, depending on the damage, as the child, if the thing evolves later on, you may have all those the clinical condition progresses, and although the insult was one time, and that you may have movement disorders coming up, you may have epilepsy and all coming up. So that is that static encephalopathy, that classical one time in the developing brain, which and classically defined to up to 2 years age. So that is why anything in the antenatally, perinatally to up to 2 years. So that developing brain, anything happening, the insult was one time. So that is why it is called static encephalopathy. But the clinically, the child may look evolving with apparently later on at the end of first year, having giving this more extrapyramidal movements and all coming, and all those movement disorders come later, epilepsy come later. One, that the talking about the epileptic encephalopathy, what we have talked about is that we understand that the epileptic encephalopathy which is there. So this is what they have classified as epileptiform activity itself is going to cause severe cognitive and behavioral impairment beyond what is expected for that underlying pathology alone. So that is what is then the epileptic encephalopathy. And the developmental encephalopathy, when you see the 2022, if you see the 2022 the paper what is published with the ILE, so they are calling developmental encephalopathy, which refers to developmental impairment without frequent epileptiform activity, for instance a child or adult with intellectual disability. But this DEE, developmental and epileptic encephalopathy, was defined formally in 2017, and which denotes for the children who have abnormal development secondary to a early underlying cause in addition to an epileptic encephalopathy. Most of them have genetic causes to that. And also in 2022, they said that developmental encephalopathy occurring in a person who has completed the development can be now called epilepsy syndrome with progressive neurological deterioration. This term, they said, you can use in situations like fires, in which a school-going children who has done this catastrophic, it should not use catastrophic, has had a new onset refractory status epilepticus and all, and you have Rasmussen and all. They have the examples which they have given in 2022. For describing a developmental encephalopathy after a person has completed the development.
What is the difference between a burst and a discharge? Why not just call it discharge and suppression? Why you want to call it a burst and suppression?
See, what you define as burst is, basically it's not one, right? It's just coming, it is coming. Why it is calling is it is characterized by by the features within the burst of the suppression and the contrasting which is there. That is why you're calling it burst and a suppression. The point is you are having this high, this for 2200 microwatt, you're getting it, and you are then getting getting a suppression, right? But the point is why it's not being, because it is the contrasting thing. That is why they are saying, calling it a burst suppression for the definition, not only the discharge.
So can we get epileptic spasms without hypsarrhythmia and vice versa?
Yes, you can get epileptic spasms without hypsarrhythmia. Hypsarrhythmia is not seen in all of the patients. And one thing is important, we discovered, it is said that you have to have a complete sleep-wake cycle to pick up these patients for the hypsarrhythmia, because it is mostly seen in non-REM sleep, and they are not picked up many times if you do not have complete this thing. And children, if you don't have a complete sleep wake cycle, so you need to have a wakefulness, sleep, and then awakening should be done. And as this thing, children with some cerebral dysgenesis are most likely to have hemihypsarrhythmia or a burst suppression pattern. So that has also to be kept in mind.
Yeah. So Dr. Shefali, I think thank you a lot for the session. Now I would like to inform all the attendees there are a lot of questions on whether the talks will be available online. Yes, after the complete course is over, and I tell this in every talk, we will put up all the talks on the Indian Epilepsy Society website. You can view it, and after about a month of this, we will have the quiz. So please, please understand that these talks will be put up, and some of you may have found the talks to be too fast or anything. You can view it at leisure and understand it, and then take up the quiz at the end of the session before you get your certification. So I think we'll end today's talk and program. Dr. Shefali, thank you very much, and I thank all the attendees. for participating, and please do become members of the Indian Epilepsy Society. Thank you. Have a good night. Thank you, Dr. Shefali.
Thank you. Thanks. Bye.